Hi, Alessandra.
Good morning, everyone. Good morning, Dr. Yang. Okay, it's 2 p.m. London time, 3 p.m.
It is 9 p.m. in China.
Okay, perfect. So I think we can start. I already published on some WhatsApp groups to join our 5th edition of TUGS Scientific Sunday. So hopefully more people will join in the next minutes. But I think we can start to not make more delay. It's okay for you, Dr. Yang?
Yeah, sure.
Perfect. So I'm going to start with a small presentation only to sponsor TUGS and our activities, and then we can go with the first speakers. Perfect. So okay, we are TUGS. It's a global community, and we are now 2,400 members from 108 countries in less than 10 months. And this is our great effort. This is our subgroups. We have 5 subgroups, so bariatric, metabolic surgery, esophagogastric cancer surgery, benign upper gastrointestinal surgery, anti-reflux surgery, and hepatopancreatic biliary surgery. This is our activities. So we have the TUGS Lounge, the TUGS Academic Group, the TUGS Scientific Sundays, TUGS Students, and TUGS National Chapters. So today we are our 5th season of TUGS Scientific Sundays. And I would like to remember everyone to give an opportunity to your students, to your residents, to speak about us and to let them know about our activities. So why you should join TUGS? This is our 5 points. This is a global community. All members can use Google Groups and WhatsApp group for discussing academic ideas. We seek to be inclusive in our approach, and I will actively involve 100% of the groups. And we have so many activities, and our membership is free. So if you want to become a member, please contact me. I will share with you the link to join our community. Okay, I think that now we can start. The first presenter will be Juan Pablo Scarano Pereira from Spain. The presentation is called Bariatric Surgery on Social Media, a cross-sectional study. So, Dr. Scarano Pereira, are you here?
Hello, everybody. It's a pleasure to be here.
Okay.
Could you please share the screen with me to share the presentation with everybody?
Yeah, I'm going to put you host, okay? Okay. Okay, you can now share.
Great. We'll open this up. Share screen. Okay. Can you see the presentation here?
Yes, go for it.
Yes.
Okay, a moment. I will set the timer. Okay. So, do I start? Okay.
Yeah.
Okay. Hello, everybody. My name is Juan Pablo Scarano Pereira, and on behalf of my research team, we would like to present you our research project entitled Bariatric Surgery on Social Media, a cross-sectional study. So, as many of you may know, obesity has turned into a global pandemic affecting an increasing number of people in both developed and developing countries. Bariatric surgery is considered to be the most impactful and durable option for patients with morbid obesity and for obesity-related comorbidities. Nevertheless, we've seen in the literature that bariatric surgery is still underused by this eligible patient population nowadays. So, what are the reasons that may lead patients not to undergo this surgery? First of all, the general lack of information. Secondly, the prohibitive cost associated to these procedures, especially in certain countries. Social stigmatization of the surgery. And finally, the general belief that lifestyle interventions are more effective than metabolic surgery for these patients, when there are several randomized clinical trials in the literature that have proved this wrong. Social media has therefore been presented as a possible solution to this problem and increase the amount of patients undergoing bariatric surgery. First of all, because it allows the dissemination of health-related messages in an efficient, functional, and transparent way. Secondly, because it's generally the first source patients may turn to before even consulting a physician. And finally, because these are platforms that enable the creation of global communities to support and encourage patients. So, the main objective of our project was to analyze the characteristics and differences of all the social media sites related to bariatric surgery on Facebook pages and Twitter accounts, and see more or less how is the current panorama and what are the things that someone interested in bariatric surgery would find on the internet. So the inclusion criteria for our study were all the public Facebook pages and Twitter accounts available on the 12th of March 2021. We used the search terms bariatric surgery, metabolic surgery, obesity surgery, and weight loss surgery. All the accounts in Spanish, Italian, English, German, and Portuguese were included in the study, and they all had to have at least 2 posts or more. The characteristics that we studied in our project were the total number of followers of each account, links to other online resources, possibility to establish communication with alternative methods other than the platform itself, the country of origin of the account, the year of creation, and the language used in the post published. So, regarding the content, we also divided all the accounts into 6 main objectives: diet and life habits, general education, medical services promotion, product promotion, medical education, and support and motivation. Regarding the authors who were publishing this content, we also created 7 categories: business, healthcare professional, medical center, non-profit organization, personal experience, research or education, and finally, support group and events. All the accounts that promoted bariatric tourism were also registered in our study. So this is the inclusion flow diagram of our study. You can see that we started with 622 accounts, but then we ended up with more or less 400 accounts because many of them were duplicated, not related to bariatric surgery, not in any of the inclusion languages, or didn't have enough posts. So these are the main results of the analysis. As you can see, there were no statistical differences in the amount of followers and linked to other online resources between Facebook and Twitter. The most important categories were healthcare professionals and medical centers, so people related to the healthcare sector. The main objective of most of the accounts was by far the promotion of different medical services. The most common countries were India, Mexico, and the US. And the most common language used in all the accounts was by far English, which went above 90%. Regarding the total number of followers, we saw that the promotion of products had the highest mean of followers with a statistical significant difference. We also saw that the promotion of medical services had the highest absolute number of followers too. So this more or less indicates us how important the promotion of different products and medical services is currently in social media. Regarding all this information, we had some conclusions. First of all, we acknowledge the great capacity social media has to create global communities. We could see as well the reach of millions of people social media has. In our study, there were more than 2.3 million followers in all the accounts. No significant differences were found between the popularity of Facebook and Twitter, which may indicate that both platforms may be effective for the dissemination of information related to bariatric surgery. We saw that healthcare professionals, medical centers, and private businesses already acknowledge the importance of social media and use them in their benefit to promote their own services. Of course, we are not concerned about healthcare professionals because if they follow ethical guidelines, they should not publish incorrect or biased information. Our biggest concern focused on non-medical commercial accounts that can disseminate unreliable information. Indeed, if you can remember in the previous slide, they had the highest mean of followers. So this was a big concern to us. Another thing, because of this, is that bariatric surgeons need to monitor and caution the patients about all the things they can find in the internet and help them more or less discriminate which are the places they should visit and the places they should not rely on. Regarding bariatric tourism, we saw that a total amount of 38 accounts were promoting in any way bariatric tourism, receiving bariatric surgery in a foreign country. The most common countries were Mexico and Turkey. This may happen because of the increased amount of facilities offering bariatric surgery at a reasonable price compared to all the neighboring countries. According to certain surgeons, this can be a problem, given that receiving bariatric surgery in a foreign country does not only have a higher attrition rate, but also an increased mortality. Nevertheless, many experts believe this is something unavoidable, something that we have to deal with. And many support the creation of a global forum to facilitate safe and ethical tourism worldwide. Regarding all the accounts centered in the needs of patients, we just saw that 16% of them were focusing on educating them about the surgery, the problems, the different side effects they could have, etc. 16% accounted for support groups and blogs with personal experience so that patients could learn from other patients that already underwent bariatric surgery. And all these accounts just accounted for 17.94% of the total number of followers, which is way smaller to all the other accounts dedicated to the promotion of either medical products or medical services. So the main conclusion of our study is that bariatric surgery is still an underutilized treatment option. Social media platforms seem to be a possible solution for overcoming this problem, especially given that they can reach millions of people. Doctors and businesses already acknowledge the importance of social media, and they use them in their benefit to promote their services and all the things they can do at their facilities. Nevertheless, the high number of followers commercial content has, along with the relative lack of followers in educational groups, could lead to problems on behalf of the patient. Indeed, what we think is that physicians especially should be more focused on educating patients, addressing their concerns, and helping them with all the questions they have, besides, of course, promoting their services and promoting their facilities. Thank you very much for your attention. We really appreciate your time. And really, if you have any question, please do not hesitate to ask us.
Thank you, Dr. Scarano Pereira. Thank you a lot for your presentation. Dr. Young, do you want to comment something on Scarano Pereira presentation? Or?
Yeah, very nice study and presentation. I like it very much. As you may know, Facebook and Twitter were blocked in mainland China, but we have another famous social media platform called WeChat. We have and also Weibo, just like Twitter. And our healthcare professionals also share their data or their information, not only for the our academic training, but also for patients' education. And may I ask, in your study, are all the accounts are from the professional healthcare providers? Do they verify their identity, or some of them, or you also included those personal accounts? Because in our country, for those who provide medical information, we need to be a doctor. We need to verify our ID in order to put some new posts in the platform. So may I ask discussion? And also maybe next step, we can try to assess the educational outcomes. Let's see how these accounts really help us to surgeons, to doctors, and also to patients. Let's see, find some way to assess these outcomes. As I think in the future, especially during the pandemic, these social media platforms very important, not only for some companies for their product promotion, but also for our educational training and also the patient education. So these are my some comments. To conclude, it is very excellent data, and you have to publish it in some journals. Thank you.
Thank you very, very much, Professor. Well, regarding the first question, the question that there are certain countries that verify the affiliations or the degrees of certain people publishing on these sites. It's true that we saw that with certain countries, but it's true that there are other countries. For example, I'm from Spain. There's no need to certify you are board certified physician for publishing this content. And I think that's the case of many different countries. So in our study, we just consider healthcare professionals if they said in their description that they were medical doctors or that they had a fellowship on bariatric surgery, and if they were board certified dietitians. So we included them if they mentioned that in their profile, we included them as such. Of course, this is something that may limit our results, because it's true that there might be people who say they are healthcare professionals, but they aren't. But well, we believe that this would be a minority. And then regarding the second question about using all these websites for educating our patients and our residents, I totally agree with you, Professor, because I think it's the future now. Everything is being done online. It has been already assessed, the power of these tools for teaching patients about other conditions such as acne or psychiatric disorders. But it would be interesting to create our own cohort to see how they learn with different social media platforms. We will have that in mind, because it seems to be a very interesting project. And thank you again for your comments. We really appreciate your comments, and we will take everything in mind.
Thank you.
We have another question from Dr. Pinter to you. And the question is, if you look for social media solution for reducing complication rate of bariatric tourism. You are mute.
Excuse me, I didn't find the button. No, we were limited in that part of the project. That's something we will have to work on in the future, because it's true that social media could be a very powerful tool to reduce the amount of people undergoing bariatric surgery. Nevertheless, we found many studies in which experts themselves said that it is something that it might be unavoidable, because now flights are not that expensive as in the past. There are certain countries in which bariatric procedures are have a reasonable price compared to all the neighboring countries. So it is something that it will be very difficult to fight against, but I'm sure that social media could have an active role. That's another idea that we will keep in mind, and that we will have for us for when writing the project. Thank you very much, Doctor.
Thank you, Dr. Scarano Pereira. So we can move on with the second presenter. Is Dr. Laundari, and the presentation is entitled Utility of Telementoring as an Intraoperative Timeout Tool During Laparoscopic Cholecystectomy for Prevention of Biliovascular Injuries. Are you here, Dr. Laundari? Yeah, I see you.
Hello, doctor.
Yeah. Can you share the screen, please?
Hello.
Hello, hello, we can hear you.
Yeah, thank you very much. Are you seeing my slide?
Yeah, yeah. Thank you.
So, good afternoon, everyone. I am Dr. Laudari from Kathmandu, Nepal. Today, I'll be presenting on utility of telementoring as intraoperative timeout tool during laparoscopic cholecystectomy for prevention of major biliovascular injury. So this is my case series only. So, I'm showing you this is a glimpse of the two hospitals of rural location with very poor transportation facilities. In country like ours, hospitals in urban areas are crowded, and often patients face long waiting lists before they can receive surgical treatment. Whereas in rural setting, there are lack of infrastructures and expert subspecialty surgeons are rarely available. In today's era of use of artificial intelligence and robotics in developed countries for safe surgery, for us, where in many places, internet connection is still luxury. The use of simple online communication tool may be of great help in preventing major biliovascular injuries in country like ours. As we all know, the reported incidence of bile duct injury during laparoscopic cholecystectomy is around 0.1 to 1.3%. As recently, the SAGES has recommended 6 different strategies for preventing bile duct injuries, and in all these 6 strategies, they have advised at least there should be the availability of 2 surgeons in the theater for better outcome and prevention of biliovascular injuries. Strasbourg et al. They have recommended 3 conceptual steps for avoidance of bile duct injury that are achieving critical view of safety. As we all know, then there is another term that is reaching the inflection point and knowing when to opt for bailout procedure. As we all know, this is another paper where Gupta et al. He has shown 3 stop points during laparoscopic cholecystectomy. First, just after the exposure of surgical field for proper GB retraction. Second, after dissection of callus triangle and achieving critical view of safety before clipping and cutting any structure. And after dissection, there may be difficulty and doubt. So at that time also, we have to seek for second opinion and the use of intraoperative imaging or performing any bailout procedure. So I just wanted to ask, where does the telementoring stand in this algorithm? So what we have done is just after exposure of surgical field, after GB retraction, use of telementoring in the country like ours, where the surgeries are being performed in very remote areas, just after doing at this first stop point, we can identify the person if we can perform the surgery in that area, or we can just simply abandon the procedure. And the another stop point, after achieving critical view of safety, we can reconfirm whether the structure is identified properly or not. And in case if there's any doubt, we can again abandon the procedure or simply refer the patient, then doing harm to the patient, or we can perform the bailout procedures. Use of mobile applications for teleconsultation and telementoring in surgery has been reported in many journals. So I am presenting my 3 case series. So this is a case of 76-year-old gentleman who was on anticoagulation, who underwent laparoscopic cholecystectomy. In this presentation, in this video, you can see, so this is a common bile duct. The surgeon has lifted the common bile duct. So, and the cystic and common hepatic duct junction has been lifted up. And here, this is the duodenum. So after showing this to the expert surgeon, after telementoring, the expert surgeon in team advised for conversion of open cholecystectomy, and so it was performed, and the prevention of major bile duct injury was hence proved. So this is another case where you can see the patient has severely contracted gallbladder and unrecognizably contracted cystic duct. So after teleconsultation, The expert surgeon in the team advised to dissect just above the umbilical fissure to the base of segment 4, that is toward above the presumed R4U line. And in this case, we did laparoscopic subtotal fenestrating cholecystectomy. Hence, again, the major biliary injury was prevented in this case just due to a simple telementoring tool. This is another case of 20-year-old gentleman who presented with the acute cholecystitis, who was found to have large pulsatile vessel in the callus triangle, and initially it was thought to be the cystic artery. Again, since it was large and pulsatile, we did telementoring, and the expert surgeon in team advised to prevent the artery, and all the tributaries supplying to the gallbladder and cystic duct were cleaved, and the right hepatic artery was prevented from major injury. As we all know, use of intraoperative cholangiogram, indocyanine green are being routinely used in other countries in remote areas. Use of intraoperative cholangiogram at times may be impractical or even cause injury to CVD in case of short and absent cystic duct, and even in case of fibrotic cystic duct. At times, interpretation of intraoperative cholangiogram may be challenging and mistaken. In low middle income countries, the ability of fluoroscopy, trained personnel, and contrast agent are the main. In country like ours, the trained surgeons are lacking. Many at times, single surgeon has to perform surgery in remote areas. So intraoperative decision making may be challenged, and the surgeon may have to abandon the procedure and refer the patient to higher centers. With use of such video conferencing application, intraoperative decision making can be improvised. In conclusion, such simple measures can aid in overcoming geographical and economic limitation for mentoring. Use of such application during difficult cholecystectomy at remote areas brings highly experienced surgeons to areas where expertise are lacking. This also allows inexperienced surgeons to perform complex procedures like difficult cholecystectomy safely and decide for bailout procedure and timely referral to reduce biliovascular injuries. So further prospective studies are required to validate such studies. Thank you.
Thank you, Dr. Laudari, for your presentation. Really interesting, really, for countries that have no directly like important expertise professor that can help you like every day and every hour. So, like Dr. Yang, do you have any comments on Dr. Laudari's presentation?
Very good presentation again, and also once again, I highly recommend you to publish these 3 cases as a case series in some journal, and to share your experience, and also about the telementoring. And in my hospital, we had some live transmission from the OR to our senior surgeons or to our mentor. They can watch our operation at their office, so they can give us some guidance immediately, even they are not in the OR. So I think this is very important, especially for the trainees or some fellows. And in regard of the research purpose, I think next step maybe you can try to compare the two ways. One is using the telementoring method. One is using the conventional or traditional mentoring method in the OR. We can compare in different groups of people, for example, how the differences between the complication rates and how it affects the learning curve for the trainees or the fellows, and also about the efficacy and the outcomes of the surgery. You may search from the database from the PubMed. You can see some similar studies. So I think you did a very good job, and keep going,
you, sir.
and yeah, and do further studies on this topic.
Thank you, sir.
Thank you.
Thank you, Dr. Yang, and thank you, Dr. Laudari. We
Thank you,
can
sir.
go for the next presentation by Dr. Chabra. Sorry if I'm not pronouncing well your last name. The presentation is entitled Structured Format Training and How to Improve the Quality of Operative Notes. Are you here, Dr. Chabra?
Hello, yes, I'm here. I'm just about to share my screen.
Yeah, thank you.
Okay.
Perfect. Yeah, we can see it and we can.
Yes, sorry, I'll just got the first. Oh, sorry about that. So good morning, good afternoon, good evening to everybody who has joined us today. I'm going to be talking about an audit we had done at the Department of General Surgery at HBTMC Medical College, which is in the city of Bombay in India. The audit was about improving the quality of operative notes, and the study is called Structured Format Training and Audit Improves the Quality of Operative Notes. Currently, I'm working as a specialty doctor at Furness General Hospital in Barrow-in-Furness in Cumbria. Since the study, I have moved here. So maintaining good medical records is an integral part of a good medical practice. Unfortunately, not a great deal of attention is paid to teaching surgical trainees the art of writing well-documented operative notes in our surgical training module in India. And I have realized that this is the same even with my colleagues who have trained in different countries throughout the world, that there is no dedicated training to document things. The Royal College of Surgeons had introduced its official guidelines of how to write operative notes in 2014. They are part of the Good Surgical Practices. It's a PDF which is available online for everybody to view as well. These are brief and easy to implement in any surgical specialty and have shown dramatically to improve the overall quality of documentation that we have. So what did we do? We did a prospective audit at HBT Medical College and RN Cooper Municipal General Hospital in Mumbai, India. This was done from October of 2020 to December of 2020. In October, we took 45 operative notes and scrutinized them and reviewed them for completeness. We compared this to a new pro forma that we had created using the Royal College of Surgeons guidelines. In November, we held 2 training sessions where we spoke to the trainees as well as the faculty to introduce them to the new pro forma. It was easier to train the trainees than it was the faculty. And in December, we did a second audit, and we again saw 52 operative notes to assess the change in compliance in filling up these operative notes. Now, you must be wondering why it was in a month why we had such few cases, because this is almost during the COVID pandemic where only we were doing emergency cases. We did modify the Royal College guidelines a bit to suit our needs better. 3 points of antibiotic prophylaxis, DVT prophylaxis, and post-operative instructions were excluded as they already are included on our anesthesia notes, and the post-operative instructions are mentioned separately. Points related to demographic data, instrument mop and Gauss count, intraoperative blood product usage, operative time, and condition of the patient post-operative were included in our notes because we thought they were important for our center. Now, this is an example of the new pro forma that we created. As you can see here, this is the hospital, the unit, and the date, name, age, sex, all the demographics that we need. They are all mentioned in a checkbox sort of way, where it's very difficult to miss mentioning anything while you read. And just to make you all understand how our papers usually are, this is what our inpatient paper looks like, where we do get to put a lot of the details that people would usually put in operative notes, including the diagnosis, the provisional diagnosis, secondary diagnosis, as well as what operation was done, to give you an idea as to where people may be mentioning things other than the operative notes. So what did we actually find? Now, this is quite simple. What we saw that a lot of things were not mentioned. So the blue shows us what the percentage of things mentioned prior, and the orange is what it was post-implementation of our study. So prior to that, you can see that there is a significant improvement in every parameter. Again, the diagnosis, procedure and operative findings, surgical count, quite surprisingly, when you leave it to people to just write aid murmur, they always forget that, the type of anesthesia as well. And as well as mentioning a very important thing is the scrub nurse's name. People would always forget to do that because they didn't think it was important. But when you have complications, you need to know who to discuss with what happened intraoperative to get an unbiased opinion. And a lot of people would only sign and forget to put their name, and nobody would usually put their registration number again, which is really important for medical legal things. So what did we understand from this? We've tried to improve these in the past as well. So we understood that the standard of operative notes could be improved along with not only with training and aid murmur, but also by using Proforma. While doing this, we found a study by Bozbski et al., which showed that using a Proforma with training rather than training alone provides much better results. And promoting the use of Proforma could help us improve documentations in other parts of our medical practice as well, is what we realized. And we have tried to replicate this by doing a similar thing for discharge cards in our center as well. My presentation is quite short and quite simple, and it's something that is very straightforward that we all can actually implement wherever we are. Thank you.
Thank you, Dr. Chabra. Anyone has some question for Dr. Chabra?
May I ask, do you use electronic medical records in your hospital?
Unfortunately, no. It's a very busy public government hospital in Mumbai, and we don't have the resources for it to be done electronically there at the moment. Everything is usually done on paper.
Yeah, and so maybe in the future you can try to use electronic medical records, and after that you will find it very convenient. And you can also collect as many data as you can, and you can export the data in a very good format, and it is very good for doing research. And after that, you can also set up a database on certain type of disease or certain type of surgery. For example, in our hospital, we use electronic medical records for more than 10 years. And we also set up our database of metabolic and bariatric surgery in our hospital. And now I also set up the national database for the bariatric surgery in mainland China. So when you collect some very high quality data, you can get some very good paper published. So I highly recommend, if you got some resources in the near future, then you can try to do it. So.
Thank you. I think there are plans in place, and they will probably be doing that in the near future. But then we wanted to still try to do what we can in the meanwhile, so that we can actually collect better data in the future. That was one of the reasons that sort of stimulated us to conduct this and then bring about this change in the way we document things.
Yeah, you can. At the meanwhile, you can collect your data in some computer software, for example, in the Excel file, or even put it in some paper printed tables. Yeah, try to collect data as much as you can.
Thank you.
Thank you, Dr. Yang, for your comments, and thank you, Dr. Chambra, for your presentation. Next presentation is the last one. It's from Dr. Thomas, and it's entitled "Rare Case of Mirizzi Syndrome with the Colorectal Fistula."
Okay, let me just share my screen.
Thank you.
Okay, let me just confirm. Can you all see my screen in the slideshow view?
Yes, thank you.
Good afternoon, one and all. Firstly, thank you, TUGS, for giving me the opportunity to present my case. I'm Joel Joy Thomas. I'm presently a junior clinical fellow in Queen's Hospital, London. And today I'm here in front of you to present a case of Meritzi syndrome, which presented to our hospital in the month of April this year, which was complicated with the presence of cholecystocholedochal fistula. So it's something that we all know about, but just like a refresher session. So let's start off with the definition of Meritzi. It is the common hepatic duct obstruction caused by an extrinsic compression from an impacted stone in the cystic duct or the Hartmann's pouch. This is Sir Pablo Louis Meritzi. He is appreciated for describing Meritzi syndrome, and he is also known to introduce the intraoperative cholangiogram. Quickly running through the pathogenesis of Meritzi syndrome. So due to recurrent impaction of gallstones in the cystic duct, and because of repeated episodes of acute cholecystitis, adhesions get formed between the gallbladder and the common hepatic duct. So what happens is, as the size of the stone increases, it causes external compression onto the bile duct, as you can see in the image. So what happens is, over time, the gallstones will cause pressure ulcer and it will lead into necrosis, therefore eroding into the bile duct and thereby causing a fistula, cholecystobiliary fistula. In some cases, we might even have a cholecystoenteric fistula, about which I will talk in my later slides. So this condition is mainly found in the age group between 53 and 70, with females having slightly greater chance of occurrence of Meritzi syndrome. Talking about the clinical picture, it's very similar to acute cholecystitis, where you have pain, you have obstructive jaundice, you have fever. Some might have gallstone ileus, some might not have. How do you classify Meritzi syndrome? We have two systems for classification. One is the Meck-Sherry classification and the Sendes classification. So Meck-Sherry is an old system of classification, which is very simple, and we don't use it in clinical in our day-to-day clinical practice. So Meck-Sherry is very simple. It's just type 1 or type 2. Type 1 when there is external compression onto the hepatic duct because of the stone. Type 2 when there is a fistula. So if you have a fistula, it's type 2. If you don't have a fistula, it's type 1. Simple as that. The important one is the Sendes classification that we use in our practice every day. In Sendes classification, type 1 is the same, where there is external compression of the common hepatic duct. Type 2 is when the fistula covers up to 1/3 of the bile duct. Type 3 is when the fistula covers up to 2/3 of the bile duct. Type 4 is when there's complete occlusion of the bile duct because of the fistula, because of stone coming in through the fistula and blocking the duct. So there's complete blockage in type 4. There is one more, that is type 5, and that is where we have the cholecystoenteric fistula. Type 5 is again divided into two, type 5A and type 5B. In type 5A, there is no gallstone ileus. In type 5B, it is complicated by gallstone ileus. One more point to note over here, in cholecystoenteric fistula, the most common connection is with the right hepatic flexure, with the occurrence of 15 to 20% connection with the right hepatic flexure. So that is the classification of Meritzi syndrome. Let's look at the incidence quickly. The most common type is type 3, that is up to 2/3 of the portion of the duct is blocked. The fistula covers up to 2/3 of the duct. And the least common is type 4, where there is complete blockage of the duct. Looking at the mortality, the percentage of mortality increases with the type. So type 1 has the least mortality. As you go ahead in the types, as you reach type 4, type 5, the mortality increases. How do you diagnose Meritzi syndrome? Unfortunately, Meritzi syndrome is diagnosed intraoperatively in most of the cases, like in more than 50%, we diagnose it intraoperatively. And the problem is, since we don't diagnose this very frequently before taking a patient to the table, the chances of bile duct injuries increases by a great margin. That is, it increases, it could be as high as 17%. Quickly, let's brush through the management as well. For type 1, that is when there is no fistula, there is just some compression. What you do is a classic cholecystectomy. You can do a subtotal cholecystectomy in difficult cases. Always go for the fundus first approach. So first, the cystic duct is identified from inside the gallbladder and then explored for looking for any residual gallstones. If you find that the cystic duct is obliterated, then don't attempt to open it further. For type 2 and type 3, that is when the fistula covers up to 1/3 or up to 2/3 of the duct, you directly go for a subtotal cholecystectomy. And remember to leave a gallbladder wall flap measuring about 0.5 to 1 centimeter. Use this flap to repair the bile duct fistula later on. Again, the fundus first approach over here, you can see the reflex of bile which will confirm that there is a fistula there. And in difficult cases for type 2 and type 3, we would go forward with the Roux-en-Y hepatococcygeostomy. For type 4, where there is complete occlusion of the duct, there is no option. We anyways go for the Roux-en-Y hepatococcygeostomy. Type 5, the most complicated type, what you do is a division and a simple suture over the affected viscera, and then you carry on with your cholecystectomy, either total or subtotal, then you go for your Roux-en-Y. Type 5B, when it's complicated by the gallstone ileus, your primary aim should be to solve the gallstone ileus first. You treat that acute condition first, and then you continue with your other procedures, that is cholecystectomy and then the Roux-en-Y for sure. Let me quickly run through my case. So this is a 51-year-old female who was admitted in the month of April in a hospital with right upper quadrant pain, nausea, vomiting, dry gas, and fever spells, the usual symptoms of acute cholecystitis. She had a deranged LFTs with a bilirubin of 70 and ALPs skyrocketing at over 1300. She had multiple prior admissions as well, about which I will be talking in my next slide. So about 6 months before that presentation, she came in the month of October, and at that time in the CT, she was diagnosed to have Merethi syndrome. So in the CT, there was a large gallstone impacted at the neck of the gallbladder. So she's having Merethi syndrome. At that time, there were no CBD stones, no CBD dilatation, and a stent was inserted at the time, and she was sent home. 2 months later, in the month of December, she came again with a blocked stent and pancreatitis. So at that time, the stent was blocked, so we changed the stent, sent her home. She came back again in the month of February. And at that time in the scan, she had CBD dilatation of 17 millimeter, and the large stone, which was seen earlier, had now migrated to the CBD. Again, another 2 months later, she comes in the month of April, and the ultrasound at that time, the gallbladder is of normal size. The stone, a 2.7 centimeter stone, is impacted at the neck. So now we know there is a fistula for sure. So what we did is we took her to theater. Oh, well, I'll come to that. Let me show you the images before that. So this is the ultrasound image. This is the CT image. I'm not sure if you can see my arrow. So the arrow is pointing onto the stone in the CT image. Over here as well, you can see the CT image of the stone. And this is the starting bit of the stent, the white one. Here you can see the stent very clearly. You can see the stone impacting the stent. Again, a similar picture. So this goes in the order. Okay, so the patient had a lap cholecystectomy and a cholecystoduodenoscopy. And what we found intraoperatively is a gallbladder mass involved in the cystic duct. There was a large CBD stone, as was there in the CT image, and this was identified on dissection, and the stone was retrieved. Subtotal cholecystectomy was performed, leaving behind a gallbladder flap. And we could clearly see a stent there when we dissected to take out the stone. So we know for sure there is a fistula with the common bile duct. We then did a cholecystoduodenoscopy, as I mentioned, and in that we found that there were no proximal stones. The stent was in place, and it was removed. Sphincterotomy, which was done earlier, was intact and looking normal. At this time, we had a video conferencing with a higher center, the tertiary HBB center, and we showed them the images of the cholecystoduodenoscopy live during the video conference and took their advice. And what they advised us to leave the cystic duct open and send the patient over to them for further management. And the patient had a Roux-en-Y procedure there in the higher center. I have a video, a quick video, which is less than a minute to show what we did in the surgery. Let me run through that quickly. So unfortunately, I don't have the video where we opened up and took the stone out. So we had done that before that. Now we are taking the gallbladder out. We're doing a subtotal colectomy. This was done by the most experienced consultant upper GI surgeon of our hospital. So we are taking the gallbladder out. Subtotal colectomy is being performed. Then now we are we're doing a cholecystoduodenal. So we're looking into the CBD, and the images were video conferenced with the higher center. So they were happy with what they saw, and what they said is just put a drain into the cystic duct and then send the patient over for the 2-in-1 procedure. And that's exactly what we did. So the patient, the very next day was transferred, had the procedure the day after. In the span of the next 10 days, 9 days, the patient was discharged without any complications. So the whole point of showing the case, discussing the case, was to understand what Meredith syndrome is, to understand the types and classification, and what is the management protocol we have depending on the classification of Meredith syndrome. Thank you very much, guys.
Really, thank you, Dr. Thomas. A really interesting case study. Thank you for sharing with us and with everyone. Dr. Yang, do you have any comments on the presentation of Dr. Thomas?
Thank you for sharing your case with us. And no special comment on this, but again, try to submit your data and submit your case with video and to some journal. Although there are not many journals accept case report now, but try your best to get published. And I would like to say more about this. The TUGS Scientific Sundays, it is a very good platform for us, especially for the juniors or fellows or trainees, to try to have our data collected and analyze our data and try to present it in a very scientific way. So the ultimate goal for a junior is to get your data published. So you guys did a very good job. Yeah.
Thank you, Dr. Yang. So I want to thank Dr. Jacques Pose, who is the TUGS Scientific Sunday coordinator. Our presentations are finished, so thank you so much to join us. And we are going to send you the certificates to your presentation by mail in the next hours. And you can see the booklet with all the abstract published in our TUGS website. So you will see that like in 1 week. And you can see also the registration of the meeting of today on YouTube in our channel in the next days too. So thank you, Dr. Yang, for your comments to moderate with me this meeting. Really have a great Sunday. Thank you and bye. Good evening.
Thank you, guys. Thank you, everyone.